Hello dear students, welcome to this class whereby we will be talking about placenta previa. Placenta previa and placental abruption, that is abruptio placentae, are the major causes of antepartum hemorrhage. So basically now in this class we will be talking about antepartum hemorrhage. What do you mean by antepartum hemorrhage? Antepartum hemorrhage refers to anti means before delivery, partum means delivery. So before delivery, that is during the pregnancy or during the gestational age, if patient comes with bleeding per vaginum or bleeding through the cervix, then it is defined as antepartum hemorrhage. So classically antepartum hemorrhage is defined as bleeding from the genital tract after fetal viability, after the fetus has attained viability, that is after 24 weeks, because now we consider the age of viability as 24 weeks. So 24 weeks से पहले अगर bleeding होता है then it comes under the category of abortion. एबॉर्शन में आ जाता है अगर 24 वीक्स से पहले ब्लीडिंग होता है. अगर 24 वीक्स के बियॉन्ड होता है आफ्टर, देन इट कंसिडर्स इन APH. Okay, but due to the improvements of neonatal survival, sometimes WHO says that 22 weeks भी ले सकते हैं in certain countries. So 24 के जगह 22 weeks भी ले सकते हैं. That varies from country to country. Now what are the major causes of placenta, that is एंटीपार्टम हेमरेज. इफ एंटीपार्टम हेमरेज पे क्वेश्चन आता है तो व्हाट आर द कॉजेज? ऑलवेज रिमेंबर, हमेशा फ्लो चार्ट्स में लिखना होता है, एग्जाम में हमेशा डायग्राम्स ड्रॉ करना होता है. सो व्हाट आर द कॉजेज? नंबर 1 इज योर प्लेसेंटा प्रीविया, दैट इज द मोस्ट कॉमन कॉज, followed by abruptio placentae. After that you have the abruptio placentae. Then there are also some local causes like if there is polyp, if there is cervical polyp which may bleed. Okay, then cancer cervix in pregnancy can also be a cause of antepartum hemorrhage. Okay, and if there is some local trauma, okay, after coitus, after physiological coitus in pregnancy can also be cause of antepartum hemorrhage. Then you can have other causes like vasa previa. We will be talking vasa previa also when we are talking about placenta previa. Then you have other causes like circumvallate insertion of the placenta, circumvallate placenta can also be a cause of antepartum hemorrhage. We'll read about all these things, don't worry. And there are sometimes you do not get any cause. If there is no causes identified, then we tell it to be indeterminate APH, indeterminate APH, antepartum hemorrhage. So always remember, indeterminate means causes not known. If it is indeterminate APH, so most of the cases of indeterminate APH later on turn out to be abruptio placentae. This is because, very important thing now I will be telling, that in abruptio placentae, ultrasound is able to diagnose abruptio placentae with a sensitivity of 35 to 65%. So ultrasound has a very low sensitivity of diagnosing abruptio placentae. Whenever there is abruptio placentae, अल्ट्रासाउंड में क्या पता लगेगा? अल्ट्रासाउंड में पता लगेगा कि द प्लेसेंटा है सेपरेटेड. व्हेन द प्लेसेंटा है सेपरेटेड, देयर इज ब्लीडिंग बिहाइंड द प्लेसेंटा. सो अल्ट्रासाउंड ट्राइज टू लुक फॉर रेट्रोप्लेसेंटल क्लॉट पता चलता है, एंड द साइज ऑफ द क्लॉट पता चलता है इन अल्ट्रासाउंड. इफ द रेट्रोप्लेसेंटल क्लॉट इज वेरी स्मॉल, इफ वेरी स्मॉल ब्लीडिंग होता है and very small detachment hota hai, then ultrasound is not able to pick up the retroplacental clot, and so ultrasound has low sensitivity for diagnosing abruptio placentae. So most of the cases of indeterminate APH later on turn out to have abruptio placentae, which can be diagnosed after bleeding when there is after delivery when there is bleeding in the retroplacental region. So once we have known what are the causes of antepartum hemorrhage, let us go into the causes one by one. So in this class we will be talking about placenta previa. Now, what actually do you mean by placenta previa? Placenta previa means it is defined as placenta located partly or completely in the lower uterine segment. When the placenta is in the lower uterine segment, this means this is the uterus. At term or during the term period, this lower uterine segment, the lower part of the uterus, it starts expanding. So the lower part of the uterus starts expanding, whereas during contractions the upper part, the muscles keep on contracting. So it contracts and the lower part expands. So this is how we differentiate between the lower uterine segment and the upper uterine segment. One question comes, when does the lower uterine segment start forming? So LUS starts forming from 11 weeks period of gestation. From 11 weeks period of gestation it starts forming, but it is immature. LUS is fully formed. LUS is fully formed at 36 to 37 weeks. So 36 to 37 weeks में लोअर यूट्राइन सेगमेंट फुल्ली फॉर्म हो जाता है, बट ये स्टार्ट हो जाता है अर्ली जेस्टेशन से ही. एट अराउंड 11 वीक्स से लोअर यूट्राइन सेगमेंट फॉर्म होने लग जाता है. सो व्हेन द प्लेसेंटा इज जनरली लोकेटेड इन द अपर यूट्राइन सेगमेंट, what is the most common site of placental insertion? Most common site of placental insertion is fundoposterior. Fundoposterior is the most common site of placental insertion, that is fundal and posterior part mein placenta is mostly situated, because implantation occurs in the fundoposterior region of the uterus. But when the lower uterine segment, when the placenta goes and starts expanding up to the lower uterine segment, then you say it is placenta previa. And placenta previa can lead to inevitable bleeding, sudden painless bleeding can be there when the patient goes into labor. अगर पेशेंट लेबर में चली जाती है, then the lower uterine segment keeps expanding, but the placenta is a hard structure and it will not expand, so the placenta will detach and there will be sudden gush of bleeding which is painless and fresh bleeding. So these are the terminologies used. Fresh blood आएगा, painless bleeding होगा, inevitable, you cannot stop it, and it is sudden bleeding, which is gush of bleeding is found in placenta previa. Now let us classify the placenta previa. Classification of placenta previa. Classifying the placenta previa. We have an older classification, we have a newer classification. The older classification says that we have type 1, 2, 3 and 4 placenta previa. In type 1 placenta previa, it is also called lateral placenta previa. Lateral placenta previa. Here the placenta is in the lower uterine segment, but not reaching up to the os, but not up to the internal os, मतलब internal os तक नहीं पहुंचा है. This is the lower uterine segment. The placenta is in the lower uterine segment, but it has not reached up to the internal os. Type 2 is called the marginal placenta previa. In marginal placenta previa, placental edge reaches up to the internal os. Placental edge reaches up to internal os. Okay, up to internal os it reaches. Internal os. Okay, so when it reaches up to the internal os, it just covers the internal os, then it is called the marginal placenta previa. Marginal placenta previa 2 can be 2A and 2B. 2A is when the placenta is anterior and 2B when the placenta is posterior. Anterior reaching up to os will be 2A, whereas posterior placenta previa reaching up to os will be 2B. Coming to type 3. Type 3 is called incomplete central placenta previa. Incomplete central type of placenta previa. It means that placenta will cover the internal os, when it is closed. So placenta is covering the internal os when it is closed, but when the cervix is dilated, when the cervix is open, then in fully dilated case the placenta tends to shift away from the cervical os. So it tends to cover the os, but it shifts away when the cervix is dilated. And type 4 is called the central placenta previa. It is complete central type of placenta previa. It is complete because the placenta is just overlying the internal os and it is not moving away when the cervix is fully dilated. So it will start bleeding and it will not move away. So these are the 4 types of placenta previa. Okay. Now type 2b, type 2b placenta previa, type 2b placenta previa, that is when the placenta is posterior. This is the spine, this is the spinal cord, or this is the sacrum coccyx. Okay. And if the placenta is in the posterior part and it is marginal, it is just reaching up to the os, this 2b type of placenta previa is also called dangerous placenta previa. It is also called dangerous placenta previa. Okay, dangerous placenta previa. Why is it called dangerous placenta previa? Because it is more likely to be compressed between the fetal head. When there is fetal head, it gets compressed between the fetal head and the sacrum, because पीछे आपका pelvis है, bony pelvis and head के बीच ये compress हो जाता है, producing compression, and this leads to fetal asphyxia, and there can be fetal death, there can be IUFD. Okay, so this is dangerous type of placenta previa. Now, how do you diagnose this dangerous type of placenta previa? Always remember, we have a diagnosing sign which is called Stallworthy sign. Stallworthy's sign. Stallworthy's sign is used to diagnose the dangerous type of placenta previa, that is type 2b type of placenta previa. So what happens is, during abdominal examination, you catch hold of the fetal head, in parabdomen examination and try to push it deep into the pelvis. So when you try to push the head into the pelvis, push the fetal head into the pelvis, into the bony pelvis. Okay, pelvis के अंदर जब हम push करेंगे तब क्या होगा? At the same time you try to auscultate the fetal heart rate पे रखना है हमारा step. तो क्या होगा? There will be decelerations, that is fetal heart rate will decrease every time you try to push, because every time you try to push the head into the pelvis, it will start compressing the placenta, and placenta दब जाएगा तो umbilical cord दब जाएगा and बच्चे को कम blood पहुँचेगा, and there will be fetal heart rate deceleration. So slowing of the fetal heart rate on pressing the head down into the pelvis and prompt recovery on release of this pressure. रिकवरी भी होना चाहिए, ऐसे नहीं कि रिकवरी नहीं हो रहा है, तो रिकवरी on releasing of the pressure is termed as Stallworthy sign and is suggestive of posterior placenta previa type 2b, marginal placenta previa, the posterior one. So this is the older classification, type 1, 2, 3, 4. Now what is the newer classification of placenta previa, grade of placenta previa? Here we have only 2 types of placenta. One is placenta previa when the internal os is covered partially or completely by the placenta. Partially हो चाहे completely हो, that is type 3 and type 4 दोनों को इकट्ठे क्लब करके बोला गया है, it is placenta previa. In the past they were classified as either total और partial placenta previa. अभी इन दोनों को मिला के सिर्फ placenta previa बोला गया. And the second type is low-lying placenta. अब इसको simplify कर दिया है classification को. So what is low-lying placenta? Low-lying placenta is combining stage 1 and stage 2. Type 1 and type 2 को एक साथ कर दिया. When the edge of the placenta is 2 centimeters from the cervical os, 2 centimeters के आसपास है, तब उसको low-lying placenta बोलेंगे. 2 centimeters से ऊपर है तो वो कोई low-lying placenta भी नहीं है. So in low-lying placenta, you can try for नॉर्मल वेजाइनल डिलीवरी ट्रायल देके देख सकते हो. इफ पेशेंट इज ब्लीडिंग देन टेक हर अप फॉर सिजेरियन सेक्शन. बट इफ इट इज टाइप 3 एंड टाइप 4, दैट इज सेंट्रल, इनकम्प्लीट सेंट्रल और कंप्लीट सेंट्रल प्लेसेंटा प्रीविया, then you have to go for elective cesarean section. Cesarean section has to be done because otherwise patient's placenta will come before the baby and baby will get asphyxiated. Okay, so this is the classification of placenta previa. Next, coming to what are the risk factors of placenta previa. Placenta previa होना normal तो नहीं है. Normally site of insertion should be fundoposterior. So what are the risk factors for placenta previa? So risk factors of placenta previa can be divided into what are the what are the factors which are leading to placentomegaly. Number 1, placentomegaly. Placentomegaly means placenta बहुत बड़ा है. दिस इज द यूट्रस. प्लेसेंटा मान लो ऊपर ही अटैच है बट प्लेसेंटा बहुत बड़ा हो गया. प्लेसेंटा बड़ा हो जाएगा तो प्लेसेंटा विल स्टार्ट कमिंग टू द लोअर यूट्राइन सेगमेंट ऑल्सो. सो कॉजेज ऑफ प्लेसेंटोमेगाली कैन बी जेस्टेशनल डायबिटीज मेलाइटिस, can be anemia. Whenever there is anemia, placenta will grow in size and it will try to give more and more blood to the baby. तो वो lower uterine segment में आ जाएगा. Also your RH alloimmunized pregnancy, RH alloimmunized pregnancy or isoimmunized pregnancy whereby there is fetal anemia and fetal hydrops हो गया तो प्लेसेंटा क्या करेगा, बड़ा हो जाएगा इन साइज टू गिव मोर एंड मोर ब्लड टू द बेबी. इन टर्न व्हाट विल हैपन इज इट विल रिजल्ट इन प्लेसेंटा प्रीविया also. Then next factors can be previous history of placenta previa. Previous history of placenta previa. This increases 12 times more risk. 12 times more risk of having placenta previa in this pregnancy. So recurrence is 12 times. Next, coming to grand multipara. Grand multipara, because grand multipara patients have generally tend to have anemia and they generally tend to have lax abdomen. Then in such cases the placental because of anemia, because mostly it is associated with anemia, there is placentomegaly and placentomegaly हो जाएगा तो placenta बड़ा हो जाएगा, lower uterine segment में आ जाएगा. ठीक है. Then previous history of any surgery like previous history of lower LSCS और previous history of DNC, ऐसे conditions में placenta previa followed by placenta accreta, that is adhesion of the placenta to the uterine myometrium, is also very common. Okay. Then increased risk of placenta previa also occurs in twin pregnancy, twins or triplets, because these twins and triplets they will have two placenta or one placenta which is very big. So basically whatever are the causes of placentomegaly will lead to this placenta previa. Also increase in placenta previa is seen in women who are smoking, because smoking will lead to cyanosis, maternal cyanosis, and cyanosed blood will not be able to provide enough oxygen to the baby. So what happens, placenta will increase in size and it will try to give more and more pure blood or oxygenated blood to the baby. Also if there is some succenturiate lobe means any other lobe which is separate from the placenta. Means if this is the placenta, whole of the placenta, and this is the umbilical cord, one lobe is separate but it is attached with membrane. So this is called succenturiate lobe. Succenturiate lobe, it may so happen that this is the uterus and placenta is situated in the upper uterine segment, but the succenturiate lobe is separately present in the lower uterine segment. So there can be placenta previa because of succenturiate lobe. So these are few of the risk factors which thereby increase risk of placenta previa and bleeding in the antenatal period, that is antepartum bleeding. So once we have identified the risk factors, let us come to the management. Okay. So management may, I have already told, I am telling again and again, every time I am telling, first we will make the diagnosis and then we will treat the patient and then we will go for follow up and prognosis. सब कुछ लिखना होता है इसमें. For diagnosis, we will start with history, examination and investigation. So history. What history the patient will give? Classical presentation of painless antepartum hemorrhage, that is painless bleeding through the cervix. And patient might so happen that patient was sleeping and she will wake up in a pool of blood, because she will not have any pain. Suddenly when there will be cervical dilatation or the lower uterine segment expands, then there will be a lot of bleeding. And severity of the bleeding, how do you know the severity of the bleeding, kitna severe bleeding ho raha hai, is known from whether there is blood staining of the heels एंड टोज. तो अगर पैर के नीचे तक ब्लड बहते हुए चला गया, देन इट इज सेड दैट ब्लीडिंग वॉज वेरी सीवियर, क्योंकि पूरा पैर बहते हुए नीचे चला जाएगा. तो दिस इज ऑल हिस्ट्री. Coming to examination or the signs, what signs do you elicit? These were the symptoms. What signs you elicit? Number 1, patient will be pale. So pallor will be present. Pallor will be present because patient will become anemic after bleeding. Okay, and it will be proportionate to the amount of bleeding. Then size of the uterus in per abdomen examination. Size of the uterus will correspond to the period of gestation, because this will help in differentiating us from placental abruption. Placental abruption में क्या होगा, प्लेसेंटा सेपरेट हो जाएगा, एंड प्लेसेंटा सेपरेट हो जाएगा तो पीछे ब्लीडिंग हो जाएगा तो यूट्रस धीरे धीरे बड़ा होने लगेगा. जब ज़्यादा ब्लीडिंग हो जाएगा तो यूट्राइन साइज विल बी मोर देन द पीरियड ऑफ जेस्टेशन इन एब्रप्शो प्लेसेंटे, बट हियर इट विल बी similar to the period of gestation. Remember this. And uterus will be soft, it will be non-tender. Whereas in abruption क्या होगा, abruption में क्योंकि blood collection होता है तो it will become hard, uterus will become hard, and it has a specific term called covelar uterus. We will be discussing in the next class. So it is that time it will be tender and hard, but in placenta previa it is soft and non-tender. Okay, then one more thing, in per abdomen examination you may find that baby is in transverse lie. कभी कभी आपको transverse lie या फिर breach, all the malpresentations मिल जाएगा. This is because if this is the uterus and placenta is in the lower uterine segment, then the baby's head will not be able to come to the lower uterine segment, because head को fix होने के लिए placenta will not give space. So what happens, head इधर चला जाएगा उधर चला जाएगा, and so baby will become either in transverse lie or in breach. So malpresentations are very common. And next thing, Stallworthy sign is what you will elicit if you think that it is placenta previa. Then head को compress करना है या lower वाला part को compress करना है, and you find that the fetal heart rate is dipping. So these are the signs or examination findings that you do. After that, once you have done the examination, you also do a per speculum examination. A per speculum examination is done, and when you insert the Cusco's bivalve speculum and try to see whether there is active bleeding is coming from the cervix or not. Active bleeding, whether it is coming through external os or not, that you try to see by per speculum examination. Always remember, per vaginal examination will never be done in placenta previa. It is contraindicated because अगर आप PV कर दोगे तो आप placenta को फाड़ दोगे, क्योंकि placenta will get injured by your PV examination and it will start bleeding. So patient will unnecessarily start bleeding. So never do PV examination in any APH patient before, until and unless you have ruled out placenta previa. Okay. Now what is the investigations? Once we have done the examination, now we come to investigation. Investigations, first of all, start with hemoglobin. You have to do the hemoglobin because you have to see patient kitna pale hai, as well as also do the platelet count, because it will try to rule out thrombocytopenia. In thrombocytopenia also patient may have bleeding PV because of low platelets, to rule out platelet count. Then do a PT-INR. PT-INR is done, coagulation profile is done to rule out any coagulopathy. Coagulopathies are ruled out by doing a PT-INR test is done. Once you have done the PT-INR and the platelets, next what you will do is you will try to look for the other investigations. Other investigations will depend. First, we will do an ultrasound examination. An ultrasound examination is done. This ultrasound examination will help us to know whether it is placenta previa. So the best modality, how do you do ultrasound? You can do either transabdominal ultrasound, transabdominal scan, or a transvaginal scan. Both can be done. Okay, in transabdominal scan, the probe will be above the abdomen and you will try to find कि placenta कितना lower आया है, ठीक है. And in transvaginal scan, you have to be very much gentle in transvaginal scan. Gentle in the sense that the transvaginal probe should not touch the cervix. Cervix तक नहीं पहुंचना चाहिए. If it touches the cervix and it touches the placenta, which is in the, if it is central placenta previa and it touches the placenta, then it will start bleeding. So keep your probe in the vagina, but it should not be so inside that it should not touch the cervix. Okay, so transvaginal, both transvaginal as well as transabdominal scan can be done. If given option between the two, then transvaginal scan is always better than transabdominal scan, because it will help us to know the exact location and extent of the placenta, because it is nearer to the cervix. But you have to be very careful. If you are not so good at transvaginal scan, then better do the transabdominal scan. At the same time, I would always like to tell you a few important things which are asked in exam. Transabdominal scan has lower frequency. It has lower frequency, but it has a larger amplitude. एम्पलीट्यूड ज़्यादा है, तो बीम्स के एम्पलीट्यूड जब ज़्यादा है वो दूर तक जाएंगे. Whereas transvaginal scan has a high frequency, but it has very low amplitude. So these are high frequency, low amplitude, and these are low frequency, high amplitude. So this is TAS, transabdominal scan wala ultrasound, and this is transvaginal scan. So what is the frequency of TAS and what is the frequency of TVS? TVS, it is 3 to 5 megahertz is the frequency, whereas TAS, it is 1.5 to 2 megahertz is the frequency of transabdominal scan. So transvaginal scan is used for diagnosing very small type of lesion which is nearer to the probe. Okay, so this can be done. At the same time, if suppose you do not have an ultrasound, you are in a PHC, then you can do a double setup examination. What do you mean by double setup examination? Very, very important. Sometimes questions come. Double setup examination. Double setup examination is that you keep the OT ready. That if there is bleeding, then I will take her up for immediate LSCS. Immediate LSCS के लिए लेने के लिए OT ready रहेगा. Anesthetist will also be ready. The neonatologist will also be ready. Everybody should be ready. And after that, what I will do is, I will do a pervaginal examination in the operation theatre, to know if the cervix के पास, whether there is central placenta previa or not. Within the cervix, अगर मुझे placenta feel हो जाता है and वो bleed करने लगती है, then तुरंत I will take her up for emergency LSCS. But if she does not bleed and I find that the cervix is dilating and the placenta is far away from the cervix, then I will give trial of normal vaginal delivery. Okay, trial of NBD. So this is called double setup examination. That is, I have kept ready for cesarean also. I have kept the system ready for vaginal delivery also. So double setup examination can also be done if ultrasound is not available, but nowadays most of the hospitals have ultrasound available, so double setup examination is rarely needed nowadays, but you should be knowing. So once I have investigated, I have known that it is placenta previa, what will be my mode of management? So mode of management can be of two types. It can be either expectant management or it can be expectant management, or it can be active management. Active management can be done. Now what is expectant management? Expectant management is also called McCafe-Johnson's regimen. So what is this McCafe-Johnson's regimen? McCafe-Johnson's regimen says that we will try to carry the pregnancy up to 37 weeks. 37 weeks तक हम प्रेगनेंसी कंटिन्यू करने की कोशिश करेंगे एंड अभी तुरंत सिजेरियन सेक्शन नहीं करेंगे. एंड वी विल ट्राई टू वाई 37 वीक्स बिकॉज fetal maturity will be best at 37 weeks and beyond. So हम fetal maturity, lung maturity होने तक पेशेंट को कंजर्वेटिवली मैनेज करेंगे एंड वी विल नॉट गो फॉर इमीडिएट सिजेरियन सेक्शन. Now what are the prerequisites? What are the prerequisites? What are the conditions that has to be fulfilled हमें अगर कंजर्वेटिव मैनेजमेंट देना है? नंबर 1, देयर शुड बी नो एक्टिव ब्लीडिंग. अगर बार बार एक्टिव ब्लीडिंग हो रहा है तो पेशेंट तो एनीमिक हो जाएगी, देन वी हैव टू टर्मिनेट द प्रेगनेंसी. तो नो एक्टिव ब्लीडिंग शुड बी प्रेजेंट. नंबर 2, पेशेंट शुड बी हीमोडायनेमिकली स्टेबल. हीमोडायनेमिकली स्टेबल because patient should be, vital should always be stable. Hemodynamically stable होना चाहिए patient. Vital should be stable, that is pulse rate less than 100, no tachycardia, and BP should be in the normal range. Okay, then the gestational age of course will be less than 37 weeks because after 37 weeks no need of continuing pregnancy because after 37 weeks chances of placenta previa bleeding will be even much more. Then NST of the baby should be reactive. If there is already fetal distress, then we will of course not go for any conservative management. And the 5th criteria is no fetal anomaly. No fetal anomaly. अगर fetal congenital anomaly है, baby को मान लो baby has anencephaly, तो why do we have to continue the pregnancy for anencephaly by giving risk to the mother? Mother's life is more important. Okay, so no congenital abnormality. Prerequisites for McCafe-Johnson's regimen. Okay, expectant management when you are giving, always you should know that if the period of gestation is less than 34 weeks, then you have to give steroid cover with best is dexamethasone. If dexamethasone not there और तुरंत डिलीवरी हो रहा है तो बीटामिथाजोन दे सकते हो. If it is less than 34 weeks, less than 32 weeks, you also give neuroprotection. Neuroprotection is given and till the steroid cover हो रहा है, till that time you have to give prophylactic also so that patient does not go into preterm labor. So these all things are same. Preterm labor PPROM chapter में भी हमने पढ़ा है. So these all things you have to give. And if the hemoglobin is less, that is hemoglobin should be more than 10 grams per deciliter. This is also a criteria, 6th criteria. If hemoglobin is less, then you have to transfuse blood also. So this is expectant management. If somebody is not fulfilling the expectant management, then you have to go for active management. That is, you have to do an emergency cesarean section. Emergency cesarean section is to be done irrespective of the gestational age if patient is bleeding. Okay, so mode of delivery is always cesarean section because the placenta is in the lower uterine segment and it will keep bleeding if the patient is not taken up for cesarean section. But if it is low lying placenta, if it is only low lying placenta, that is grade 1 and grade 2, and the placenta has moved away during cervical dilatation, then you can give trial of labor, but then your OT should always be ready. Double setup examination has to be maintained. Okay, so this is all about placenta previa. Now at the same time, I would also like to tell you about another entity which is called vasa previa. What is vasa previa? Vasa previa is just like placenta previa, but you should know what is vasa previa. Vasa previa occurs due to velamentous insertion of the cord. Velamentous insertion of the cord, that is, cord is inserted onto the fetal membranes. Now suppose this is the placenta. This is the placenta on one side. Okay, this is the major mass of the placenta. Now what happens if there is a succenturate lobe? What do you mean by succenturate lobe? I told you that one more lobe is there and this lobe is here. Okay, this lobe is here. So in between the lobes there will be connections. In between the lobes there will be connections. Now this connection, somehow this connection is overlying the internal os. Okay, cervix के ऊपर ये connection है. तो these blood vessels are running near the cervix. So when this patient goes into labor and when the fetal head pushes down, so what will happen? The head pushes down, these blood vessels will tear and it will start bleeding. So it is vasa previa, it is not placenta previa. Placenta previa में the placental mass is overlying the main placental mass or the subcenturiate lobe is overlying the internal os. तो यहाँ पे क्या होता है प्लेसेंटा प्रीविया में? इट इज़ द मैटरनल ब्लड जिसका ब्लीडिंग होता है, मैटरनल ब्लीडिंग ऑकर्स, मैटरनल ब्लड वेसल से टेयर होता है बिकॉज प्लेसेंटल मास इज देयर. But here what happens? Here the subcenturiate lobe is there on one side and placenta is there on one side and the communicating vessels tear होता है जिससे bleeding होता है. So basically this is the fetal blood that is lost. It is the fetal blood that is lost. So vasa previa is more dangerous to the baby. मदर को ज़्यादा दिक्कत नहीं होता, बस बेबी तुरंत आईयूडी हो जाता है. वेरएस प्लेसेंटा प्रीविया में बेबी ठीक ठाक रहता है, mother becomes anemic. So this is the major difference between vasa previa and placenta previa. So blood loss is basically in fetal origin and it has very high mortality for the baby. 75 to 90% of IUD, that is fetal death, is associated with this, and maternal mortality cannot be increased. So it is diagnosed by, how do you diagnose it? Diagnosis is by ultrasound with Doppler. डॉपलर कराना पड़ेगा. तो जब ब्लड फ्लो देखेंगे तब उनको पता चल जाएगा कि फीटल ब्लड फ्लो इज डिक्रीजिंग, सो फीटल ब्लड इज बीइंग लॉस्ट. And one more diagnosis is when you do a NST or CTG. In NST or CTG, there will be a specific pattern of heart rate which is seen, and this is called the sinusoidal pattern. This is called the sinusoidal pattern. Sinusoidal pattern means there is no acceleration, there is no deceleration, but it is sinusoidally rotating around the same place. So sinusoidal pattern. Sinusoidal pattern is a प्री-टर्मिनल इवेंट मतलब बच्चा अब भाई मरने ही वाला है, अगर तुरंत सिजेरियन नहीं कराओगे तो ये बेबी विल डाई immediately. So pre-terminal event. So this sinusoidal pattern, very very important, asked in examination, is found in either बहुत ज़्यादा fetal asphyxia या fetal distress है, या फिर what are the DTs of sinusoidal? Number one, when there is very severe fetal distress में baby can have this sinusoidal pattern. Number two, if there is fetal hydrops, hydropic baby में बहुत ज़्यादा एनीमिया है and there is very much of hypoxia, so RH isoimmunized pregnancy जब fetal hydrops होता है उसमें भी sinusoidal pattern है. And number three is vasa previa. Whenever there is vasa previa, there is bleeding from the baby's blood vessels, so there will be this thing, sinusoidal pattern. One more thing, one more test that you can do here is alkaline illusion test. Okay, so what is alkaline illusion test? This is also called APT test. APT test में क्या करते हैं? APT test में we take the blood. Okay, we take the blood which we have got from APH. Okay, because of vasa previa जो blood मिला है उसको ले लेते हैं. We take it in a slide. We make a slide and then you add alkali. That is, what alkali do you add in this? You add Singer's alkali. Singer's alkaline solution. This Singer's alkaline solution is a mixture of potassium hydroxide and sodium hydroxide. Okay, so a combination of potassium hydroxide and sodium hydroxide diluted is added to it. So what it will do is, it is a denaturation test, alkaline denaturation test. That is, all the maternal RBCs will again be denatured and this will turn into ghost cells, whereas fetal hemoglobin बहुत strong होता है, fetal blood RBCs will not be denatured and it will remain. So यहाँ पे पता चल जाएगा कि कितने ये जो bleed हुआ है वो mother के blood ज़्यादा bleed हुआ है कि fetal blood. So basically in this, when it is vasa previa, you will find more of fetal hemoglobin, fetal RBCs more होगा, whereas if it was placenta previa bleed, then placenta previa bleed में you will find very less fetal RBCs, will be very less, and it will be more filled with mother's RBCs which are already denatured. Okay, so this is the difference between apt test differentiating between placenta previa and vasa previa. At the same time, I would like to remind you of the class of RH नेगेटिव प्रेगनेंसी. RH नेगेटिव प्रेगनेंसी में भी हमने एक टेस्ट का नाम पढ़ा था जिसका नाम था क्लीहोर बेट केस टेस्ट, KB टेस्ट. KB टेस्ट में भी वी डिड द सेम. वी ट्राइड टू फाइंड कि कितना फीटल RBC है among the mother maternal ghost cells, but that was an acid illusion test. उसमें हम क्या किया था, एसिड डाला था. The mechanism is same, but we had used acid. What acid? CPD, that is citrate phosphate dextrose buffer डाला था, citric acid डाला था, and we had denatured the maternal RBCs, fetal RBCs रह गए थे. Here we are adding alkaline, alkali डाल के हम इसको denature कर रहे हैं. So this is called apt test or alkaline illusion test, which contains a mixture of KOH and sodium hydroxide, which is called Singer's solution, Singer's alkaline solution. So remember these two tests. So अगर वासा प्रीविया है, ट्रीटमेंट क्या होगा? ट्रीटमेंट होगा emergency cesarean section before the baby dies. Okay, so this is all you have to know. So this is all about placenta previa and vasa previa. In next class, we'll be talking about abruptio placentae and how to differentiate between abruptio placentae and from placenta previa. What are the risk factors? Those we will study in a different topic. So I hope you have understood. Any doubt, anytime you can ask me. You can call me up or you can send me message. Thank you so much.